Terrific. Well, my name's John Spurtis, and with Stacey Barr and Pat McDonald, we are trying to launch the UNKC Healthcare Institute for Innovations and Quality, and I am really excited for this session. But up front, I have to, I don't know, make an excuse, come clean, whatever. My daughter's getting married on Saturday. There are people flying in right now, and I used up all the chits in the world to come and launch this because I was so excited about the speakers and the presentation. But I'm going to take most of it by phone because if I don't get back home and start helping, I'm not invited to the wedding. So it's a real challenge for me. But I'm very, very appreciative, and I just wanted to provide some context for why I'm so excited about this presentation. So the Healthcare Institute for Innovations and Quality is a regional collaboration that is seeking to work towards Kansas City delivering the highest, most equitable healthcare in the nation. And we're going to accomplish that by catalyzing and facilitating multi-stakeholder collaborations to improve the quality and value of care in our area. And, you know, what this started back in 2016, 17, 18, when we were part of the regional CTSI and felt that the critical lack in the translation of research was actually getting it into routine clinical care and practice. And so towards that end, we wanted to take advantage of a growing pressure on healthcare systems to move from volume to value-based care. And while this has been very prevalent on the coast, it's not so common here. And, you know, when we started, it was before sort of the Trump administration derailed all of the incredible pressure that Medicare was doing. But it was very clear that we were moving in this way. And for our region to do well, if we all collaborated together, if we brought together the payers and the patients and the providers and the researchers to work as a force, we would be very well positioned to handle the evolution of healthcare financing. And so we have three broad strategies that we are embarking on to help accomplish this goal. The first is a series of regional quality improvement projects. We started with the opioid crisis in the emergency room and transitions in care and heart failure. Next year, I think we're going to start to launch. We have a working group about maternal health. But, you know, it turns out that doing implementation science and figuring out how to implement change and measure the quality of implementation is sort of a field unto itself. And so under Danielle Olds and Stacey Farr, we've launched a program to help train really providers, researchers to some extent, but mainly providers in implementation science. It's sort of the cliff notes of implementation science. And this is a certificate program, and I think it's a very powerful way to have everybody speaking the same language. And then we have these forums. These are opportunities for us to vet ideas, concepts with multiple people, some on Zoom, some in person, to think about challenges facing healthcare today. And, you know, we want to think about, and what I like about this is it's really trying to gather insights in how to encourage value-based healthcare. So everybody will acknowledge that, you know, healthcare decisions should be evidence-based, they should be patient-centered, and they should be high value, they should be cost-effective. If you're going to get the same outcomes with an expensive or an inexpensive course of therapy, why take the added risks and expense if you'll do just as well with an alternative strategy? But to support that kind of care, payers and providers like health systems have different challenges and tools at their disposal. The payer strategies can be creating very narrow networks, you know, contracting or giving preferential access to those providers that provide the most cost-effective care. They can create very restricted formularies to try and lower the cost of expensive medicines. You're kidding.
No, because I just logged in. Sorry. I just logged in, so I was like, oh.
Everyone online, we just want you to know we're having a tech glitch. It's showing now.
Okay. Well, I apologize that it wasn't showing. The slides were absolutely beautiful. And I believe there should be a benefit to those who make the effort to come in person. So they saw it, but so I was saying that, medical decisions need to be evidence-based, patient-centered, and cost-effective. And, the payer strategies to help support or encourage that are creating very narrow networks where they preferentially direct the their covered lives to those centers that provide the highest value healthcare, very restricted formularies, pre-authorization, which providers and physicians just love, where you have to justify why you want to do that, or really to create value-based contracts where, they try and create an economic incentive for the providers to make more money by practicing higher value healthcare, but they don't try and micromanage the processes and in which that care is delivered, which, creates a lot of pressure on the provider organizations to think about, well, are we going to develop care protocols, and how are we going to monitor adherence to that? Are we going to give decision support tools, and how do we train our providers to use these and to really leverage them? Or can we create economic incentives? And we are very lucky to have somebody traveling in from out of town, John Masudi, to talk a little bit about that. But to me, I think that's got to be sort of the key strategy. This is a project that we've described in the past in this setting, where we've got a multi-tiered strategy for trying to reduce or interrupt the carousel of healthcare, one of which is the Code HF. This is a means of risk stratifying patients showing up in the ER with a history of heart failure to see who really needs to be admitted and who doesn't. And when we implemented it at St. Luke's, we had a 49% increase in patients being discharged out of the ER. The length of stay, the time in the ER, because when we first introduced this, the doc said, oh, it's too time consuming, we're too busy, whatever. It actually cut the time in the ER by 50 minutes, almost an hour. 30-day readmission, so after they left the hospital, were cut by a quarter, meaning that we were sending the right patients home as compared with usual care. There was almost a doubling of early follow-up in the cardiology department, and unnecessary admissions. People who were admitted less than 48 hours, we could only bill as an outpatient, not an inpatient, dropped by a fifth. All of these are great, but yet the pathway was only used in about 12% of patients. And when we looked at individual providers, this is all the providers in the system and how often they use the Code HF pathway. And the vast majority really don't use it at all, whereas a few really embraced it. So how is it that you create the motivation, the incentives, the drive to get people to follow evidence-based protocols? Another example where I think there's a potential strategy here is some early anecdotal experience we had in trying to support more cost-effective anticoagulation during the time of angioplasty. So anticoagulation is a critical component of doing stents. Heparin costs pennies a patient, but bivalirudin, which actually does cause less bleeding than heparin, was about $750 a vial when we were doing this study. And the greater the risk of a patient for bleeding, the more benefit they get, the fewer patients you have to treat to prevent a bleeding event, and bleeding events can be very expensive. So you would preferentially want to use this therapy in patients at higher risk for bleeding, but in practice, there was no association with bleeding risk and bivalirudin use. So this is, we had the luxury of doing a 9-center study where we had 137 interventionalists, 7,500 patients. And if they were rationally using bleeding avoidance strategies, in the lowest risk patients, they probably wouldn't need any. But as the risk grew, then you would expect them to start using this therapy. And so this is what an ideal curve would look like. But in reality, this is the practice we observed. So by far and away, people either are using it or not using it, irregardless of risk, or they're using it more in the low-risk patients than the high-risk patients. And to make that sort of more tangible, if your grandmother had to undergo angioplasty and went to one of these centers, and these are great centers. I mean, it was Mayo and Yale and Baylor and University of Washington University at St. Louis. And if they went to one of these, they got referred to Mayo and they were going to get angioplasty and they had a 10% risk of bleeding. You would absolutely want them to get a bleeding avoidance strategy. And yet their likelihood of getting it, depending on which doctor they saw, would vary between 1 and 100%. You know, this is sort of crazy. And so at St. Luke's, we had been using a system like this for a long time. And what you see is a general trend where our interventional cardiologists use it less in the low-risk patients, more in the high-risk patients. This is good, but there's still a lot of variability by docs. And so in December of 2012, the hospital bought the cardiology practice, and they were developing performance metrics. You know, there was a salary bonus if you met a certain milestone, and a lot of them were, you know, doing, clearing out your Epic inbox in 48 hours, you know, electronic prescribing, things like that. But, and I'm not saying how the chief medical officer got this idea, but one of the metrics turned out to be more rational use of bivalve route of the cath lab, so that if these 9 doctors would follow a more rational pattern, that all 60 cardiologists would get a 1/6 of their quality bonus. And this is what practice changed to, you know, highlighting that if you have the right leverage, you can actually really affect change. And with this, you know, our predicted bleeding rate was about 1/3 of our actual bleeding rate was about 1/3 of what was predicted. So lower costs, better outcomes with more consistent care. So summarizing the context for this, you know, physicians all wake up trying to deliver the highest quality, highest value healthcare. However, real practice is quite variable. And while payers can encourage systems to practice high-value healthcare, how those provider organizations can actually do it is not really clear to me or to anyone. It's difficult. Changing physician behavior is very difficult. And so the question and the purpose of this forum is, how do we think about incentivizing better, higher value, more equitable healthcare? And so we're very fortunate to have speakers from different perspectives. Jill Watson is the executive director of Centris, which is a learning healthcare network that has at-risk contracts with payers. And so they've been working at this for quite some time. We're very fortunate that John Masudi flew in to present the innovator's perspective, how you can think about promoting value-based behaviors in primary and specialty physicians. Lee Norman is going to talk about the payer's perspectives on strategizing to incentivize value-based care. And the provider perspective will be provided by Luke Harris, who is at Children's, and we'll talk about innovation through iteration, deploying value-based care incentives across the continuum. So without further ado, I'm going to sneak out, but I'll be listening to the rest of the presentation. And thank you all so much for making the time to present and sharing your experiences, perspective, and wisdom.
I don't know that I'm needed up here, but I'm just gonna check in here with Jill to make sure everything's going well.
I am sharing my screen now. Are you able to see it?
Yes, thank you, Jill.
Okay, great. Good afternoon. I'm Jill Watson. As Dr. Spertus said, I'm with Centris Health, which is a clinically integrated network here in Kansas City that's owned by 3 competing health systems, and we contract with all of their employed providers as well as a good number of independent practices to do value-based care in Kansas City. And we've been doing value-based care about as long as there has been value-based care in Kansas City. So I feel like we're as keyed in as anyone around what the market looks like here in town. So we'll advance. So this is a little bit about what Centris looks like. We're about 3,000 physicians, over 500 locations at this point. And we, as a clinically integrated network, are a single signature for all of those physicians, and then the facilities have separate contracts for facility incentives. So these are, you can see on the screen the partners that are involved. So it's a high level of complexity. I do a lot of cat herding. But we've been at it this is 7 years now. So happy to be able to keep it going. And 22 was a really a year that turned the corner for us. So happy to tell you more about that in a bit. So Centris Health is a lot of things. When we first came to the market, people really didn't understand this concept. There were not a lot of clinically integrated networks in the market. Luke's and ours have been the bigger ones for some time. But a clinically integrated network, Centris Health is an organization that is many things. A clinically integrated network is one, and it's operationally probably the biggest piece of what we're doing. It's also an accountable care organization, which I say is generally a clinically integrated network with a contract. We have a population health services organization. We certainly are a provider network. We're owned by health systems and led by physicians, and we are very much a collaboration of competitors, which is an interesting place to be. So we got into value-based care. So Centris was stood up in 2017, and we took our first contract in January of 2018, which is different. Many clinically integrated networks stand up and then don't have a contract, and so they fizzle. And we did not want to have that be our experience, and so we sort of timed the development of Centris at the same time that we thought the market was changing and that there was an opportunity for a contract. So. We've had 2 contracts and actually since day one. So we wanted to align incentives. We knew that the market was seeking alternatives to traditional fee-for-service. You know, at that time, Medicare had already made a bold claim that it wanted to have 100% of Medicare beneficiaries in value-based care and now it is by 2030. So that's getting close, very close. Commercial payers are trying to retain their customer base. And, you know, we are providers that have been in this community for a very long time and love Kansas City and want to see it thrive and attract business and all those things that make Kansas City the great city that it is. The great region that it is. So certainly wanted to further that and to access the new revenue sources that value-based care presents. And of course, always looking to increase patient attribution. So things we've learned in 7 years, and this is the bulk of my slide, but I'll take a little bit of time on each of these points. So patient-centered care is imperative. We built Centris on the backbone of the patient-centered medical home concept, and our region had already gone through that philosophical change back in the day. So because we were a comprehensive primary care plus market very early, so we had advanced primary care here, and so Centris easily aligned to those capabilities and stood on top of that. So, and that continues to be an important piece of, you know, what it takes to be successful in value-based contracts. I'd say contract terms make or break the deal. And the thing that's interesting about Kansas City is we have our own Blue plan here. And so they were able to be creative and did not have a national program that they were asking everybody to take or leave. Which is what you see from the big payers, the bigger payers like United and Aetna and Cigna are offering programs that they want to roll the same thing out all over the country. And so that may or may not work for where you know, providers are in any given time in any given market. So that we found is harder to deal with. I'd say payers also are learning too. We have contracts with big, large insurance companies, but they also have been iterative. So they're learning as well as providers are on what works and what doesn't work, what they can actually support and what they can't support. And so, there's just been good learning all along the way. I'd say again, on contract terms, we've had lots of amendments to contracts. So in no way are we still operating on the same contracts that we signed whenever we got into them at the first time. Those, we continue to go back to say, this is something that's not working. Let's make an amendment to fix it. And that happens, as I said, on both sides. Also, we have actuaries now, which is something that providers typically have not had. That has been something that payers had an upper hand on. They had a lot more math than we did. And now we have the same math or better. And so that's been very helpful to helping us understand which contracts can be helpful to us and which ones, really are not good. The scariest thing about value-based care is that it's brand new and nobody knows. There hasn't been a lot of experience in it. And so a lot of trepidation in the early years about being first. But Centris very much was a first mover in the adult space. Anyway, Luke's group has been at this for a long time too, so I don't want to discount that at all. But definitely blazing trails here. Quality is table stakes. I would, this is a quality improvement organization. High IQ is. I've been part of lots of quality improvement organizations over my career, and that has all been very worthwhile time. So worthwhile probably that now it's just expected. There's not a lot of extra points for high quality. It's more likely to be punitive for poor quality. So that is table stakes. So it's provider groups certainly have to have the quality improvement piece down pat and know how to do that, know where they're lacking and what they need to do to improve. And then data. Data is a huge piece of value-based care. And bidirectional data feeds are critical. They're hard to set up on both sides, and lots of workarounds have existed to, in the meantime, as interoperability has sort of taken hold or tried to take hold. It's by no way all the way there, but you really can't do value-based care well and feel like as a provider group you're super well represented and that your data is accurate and timely without faster data feed and data exchange than what we've experienced recently or up to this point. So those would be sort of the 6 big ones. I know we're trying to, I don't want to take more time than I was allotted because we have a lot of good speakers coming up, but where do I think value-based care leads? We are providers working together to remain independent, committed to higher quality, affordable care. Payers and brokers and employers want collaborative partners, and so we are trying very much to be that way. But also feeling a need to reduce reliance on the VUCA payers. And also I would just acknowledge that private equity is entering the provider space, which is, making things interesting. And we have to be cognizant of all of those things. So more complication, not less. People crossing into different sectors than they'd been in the past. And so we think that value-based care aligns very well to direct contracting. And so that is something that we see this market getting very interested in, typically with small to medium-sized employers, which is where Kansas City is very well stocked, but looking to be more creative than what they've been able to do with a traditional broker and a traditional payer relationship, and trying to go directly to providers. There are lots of, I think, similarities and value-based care capabilities that align well to direct contracting, and I've listed some of those on the screen here. I'm happy to talk about that more if there's interest, but that's where we think value-based care is leading. Certainly we will keep doing more and more value-based care, and I'm happy to say that the smarter we get and the more experience we get at doing it, that we are starting to have some participants say the riskier position is to not take enough risk. That in fact we are creating more value than we're getting from value-based contracts under some of the contracts that exist. And so just reaching the level of sophistication so that you can get a larger piece of that value and savings is where we need to go, which is a very different place than where 3 health systems started 7 years ago, where it was try to take as little risk as possible. It's been quite an evolution, and I hope you appreciate what a change that is for someone to be telling me that the riskier position is to not take enough risk. So very different. With that, I think I've used my time, so I will have some time for questions. And like Dr. Spertus, maybe not quite as big as a wedding, but tonight is my daughter's senior night for volleyball, and so I have to be at high school in a little while. So I will try and take Q&A from my phone. But I'm happy to. I listed on at the end here my contact information if you want to reach out. I'm happy to share, answer questions, or whatever I can do to be helpful.
Jill, thank you. Thank you. And if you stop sharing, then John Masudi will put his slides up. Jill, thanks so much. Go fight, win.
Yes, thank you.
Oh, here you go. There you go.
It's right here. Great. So I'm John Masudi, and I'm very glad to be with you today. I'm grateful to Pat and to Dr. Spertus, who is hopefully driving safely right now, for having me out and supporting me.
Sorry, sharing the wrong screen.
I'm sharing the wrong screen.
At least it is on my view, right?
Okay.
Online, others, yes. See, please.
Yes.
Yeah. Sorry.
Thank you for your help.
Like, wait, we don't want to see that. We just want to share screen. And
There we go.
Is that it?
there.
Thank you very much. I appreciate that. So I'm going to start by telling you a little bit about myself and my career, so you'll understand the perspective that I'm looking at this from. I am a urologist, and I finished training in 2000, and I loved it. I loved being a urology resident. And then I got into this great private practice in New Jersey, and I hated it immediately. And I hated it because I could see other people doing things that didn't make any sense except for money. They would say things like, oh, this patient has a 2 millimeter ureteral stone. Better get it out before they pass it on their own. And I just didn't like working in that environment. And I left and I moved back home to Colorado, where I got the only job that was available as a urologist, and it was in the Colorado Permanente Medical Group. And I didn't realize what an important moment that was for me, because it set me off on this career in value-based care. And I loved it, being at CPMG, because we practice value-based care. And so I'm particularly interested in physician behaviors and value-based care. And so that's what I'm talking about today. And I typically come at it from a provider perspective, from the perspective of a system that employs physicians or has a very tight relationship with physicians. So I will go, somehow this is not letting me go to the next slide. My clicker's not working.
Clicker's not working. On it, what a day.
The space bar. Oh, there
we
it is.
go.
Space bar works. Okay, this is one of my favorite quotations by the hilarious Mark Twain. This is how I feel right now. It's very hard to give a short talk on this, but you can talk faster. So that's why I sound a little pressured and I'm speaking quickly. Here's another one of my favorite sayings, and this has a lot to do with our current healthcare system and fee-for-service medicine. Carol Jean Borman was my mom, and she would say this:
You know, if you bought something that was cheap and it broke down, well, you get what you pay for. And that's the usual meaning of this. But that doesn't apply to fee-for-service medicine, because in fee-for-service medicine, we spend a ton of money and we get pretty crappy quality. The amount of money that we spend gives us poorer quality compared to other countries in the world. But in another way, I like this saying because it has two meanings. You get what you pay for. So if you pay for more healthcare, you get more healthcare. And in fee-for-service medicine, that's what you do. Here's a representation of the choices that a physician can make when they're confronting a problem. They can choose to be on the more aggressive side of things. So let's say someone comes in with back pain. They could say, oh my gosh, you need spine surgery. That'll be $30,000, please. Or you could say, let's do some stretches and exercises and get you better. Just give it some time. Let's wait. And that's on the less conservative side. Well, fee-for-service medicine pays on the micro level. When a doctor and a patient are making a decision, it pays the doctor more if they do the more aggressive thing, whether it's prescribing a medication, doing surgery, ordering tests, all that stuff. And so what do we get on a macro level is we wind up on this curve, which should be familiar to most people. It's the curve of diminishing returns. And it's the relationship between an input of some effort and the output of a result. So this could be anything. It could be how many times you tell your kid to clean up their room and the likelihood they will do it. The more you do it, you know, for a while it works, and then you start having a negative return. And in the current American medical system, we are definitely on the negative returns part of this chart. And what that means, there's bad news and good news. The bad news is we provide very expensive and not very great quality healthcare. But the good news is we could improve our quality and reduce our cost at the same time. We have to move from producing too much healthcare to producing the right amount of healthcare, which is a lot less than we do now. And so how do we do that? What I want to talk about is how do we change physician behavior from this fee-for-service behavior that's all about cranking up RVUs, which have nothing to do with results. So we used to say at CPMG that doctors care about two things: call and pay. That's pretty much all they care about. I would add one thing to that. So I would say compensation is important to doctors, and they will do what you pay them to do. The care model is sort of, how easy is it for them to do the right thing? Do they have help with, you know, care coordination and things like that, and risk assessments? And the last thing is professionalism. We have seen a trend amongst physicians to move to a unionized workforce. And that is a bad sign for medicine. It's a sign that the professionalism in medicine is decreasing, that people feel helpless, their job is changing, they don't have control, and they're trying to unionize. And physician autonomy is a really big part of how you can affect physician behavior, because if you treat them like adult professionals, they'll really like it. And if you can do that, then they'll also do what you need them to. So let's go through those levers for primary care. It's almost a truism that if you pay providers with the same risk that the payer gets paid with, that their interests will be aligned. So with Medicare Advantage, it's a capitated system. If you pay physicians in some way that mimics that capitation, they will start behaving differently than if you just pay them to do more stuff. And then you need to create a care model around these primary care docs where they can manage a panel of patients who all have the same care model. So I'm a Medicare Advantage doctor, or I'm a capitated doctor, and I don't have to shift between these two models of care that are essentially polar opposites. So it's about concentrating the value-based patients amongst certain providers. Then when it's time to train somebody on, let's say, risk adjustment, If risk adjustment has a lot to do with their work, they're going to pay attention. They're going to do it in a compliant and accurate way. But if each person has 5 or 6 patients, they're not going to do that. And then professionalism is all about, I have a panel of patients I'm responsible for, and I'm responsible for their cost of care and their quality. It's on me, and I can do it however I want. Don't tell them how to do it. Let them figure it out, and they'll figure out some really cool ways of taking care of patients safely and in a high quality way that uses the right amount of healthcare. Specialty care is much trickier because really the biggest winners in fee-for-service are specialists, especially the ones who do procedures. So salaried specialists are the best specialists for value-based care, where they get paid for taking care of patients, not for what decisions the patients make. A care model around specialty should be about having value-based champions who will do things like review referrals and train the small group of primary care docs on some low acuity specialty things like what to do with back pain, what to do with a kidney stone, so that they can take care of that on their own, which increases their professionalism and their satisfaction and keeps the patient out of the specialist's office. Here's another one. Eliminate conflicts of interest where you can. The reason I hated being in a fee-for-service model is I could feel that conflict of interest changing my behavior, and I didn't like it. And most people don't like that. And so if you can eliminate that, I'll tell you a way that we did that in Permanente that I think is useful is for certain procedures where we could do this, like cataract surgery, we would have the person making the decision if the patient had a cataract be somebody different than the person doing the surgery. So you had to see an optometrist first. They would say, yeah, you have a cataract. They would send them to the cataract doctor. And if they agreed that it was appropriate, they would do the cataract surgery. And we created a program where we could do cataracts for $900 an eye, because the people who did them were doing $1,500 to $2,000 a year with the lowest complication rate in the state, and in an office-based setting, because these docs didn't own a surgical center where they could make extra money by doing the cases in a surgical center. So the time here is short, but I want to talk about some things for legacy health systems, which I would call, university health systems, or, these systems who've been value-based or fee-for-service forever. Like, what are the problems they have? One is that they're addicted. It's like cocaine. Fee-for-service is like cocaine. You just, it's the only thing that they want. And so they don't see that they can make money in value-based care, but there are other organizations making money in value-based care. And these systems can either get on board or get out and let somebody else make the money, and they should not be doing that. They should be providing better care in a world that's going towards value-based care. And culture is a big issue there. Another problem is you cannot pay physicians in a fee-for-service way and get value-based care. It's impossible. It's impossible. So you have to create a different compensation model for your MA patients or whatever value-based contracts you've got. Payers, they have so little control over care delivery that they really struggle. And I believe the way to get them to change physician behavior, well, I'll tell you a story. Okay, so my story is that I have a lovely daughter who's off in boarding school, and she put my credit card on her phone. So wherever she would go, she would charge stuff to my credit card, and I didn't notice for a long time. And she came home and I added it all up, and it was like $300. And I just said, hey, you owe me that $300. And guess what? She stopped spending my money because it was now her money, right? And payers need to make it so that providers know it's their money. They have to pass full risk on to providers. That's the way payers are going to get this done. And my advice for the future is, for legacy health systems, you either embrace risk, financial risk, or you're going to be in big trouble, because financial risk is the future of healthcare for providers. And that's where the financial risk belongs. It belongs with the people who control the care delivery system. And so, and I would say for systems and physicians, embrace the risk, because it's the only way out. And people don't know that. They're going to keep going back to their crack pipe of fee-for-service medicine, but that's not the way out. So thank you, and I'm glad to take questions when the time comes.
I'd be happy to have your assistant.
Every time I come, it just blows up, but so. There.
It's not that I
I
can't
think
do it.
I'd-
I just can't have my thing don't work quite.
You just leave it on screen. It'll,
Can you see it online?
no, you have to stop sharing and share screen, share that first box.
I did share. I did stop sharing.
No, I mean
I share
the
screen.
top left. Just click the screen, just where it's at, just share.
Oh.
And-
Ah. There you go.
And then pull the slide.
You can see it now?
Yep.
Okay.
We're good.
Screen size.
Uh-oh.
Somewhere, isn't it?
It is, but it's not showing itself.
On the
Um,
bottom,
here we go.
right there. Yeah.
Well,
Oh. Two over, yeah, two over from that one.
step right on up.
There you go. Oh, I
Pick
can
the
see it. I see it right there.
That,
No, below it. That one.
that's what I hit.
Oh,
Nope.
there we go.
I guess I did.
Just
Thank-
one of the
thank you.
ones.
Hi, my name's Lee Norman, as you can tell. That was really, I've liked these two talks. There's a lot of things that are fitting together. I think that we have a little bit different angle on things, but they're really coming together. And I love a little bit about me. I've been, just so you know what reference point I come from, I think I've had about 5 careers now. I've been a family physician for 40+ years. I just retired from the Army at the end of last year, about a year ago today, as a matter of fact. I spent 6 decades in the military, between my Air Force career and then back during Desert Storm, and then in the Army. I enlisted when I was 61 and shipped out to basic training when I was 62, and stayed in until I got the boot a year ago. So 26 years of active service and a bunch of others. And the reason I bring that up is because you talk about a non-fee-for-service based practice between being active duty and reserve in the Air Force and active and guard in the Army. When there's not a fee-for-service motive behind it, it brings up a whole different set of expectations and drivers, as our prior speaker talked about. When I came back from Army deployment for the 16 months in 2017 and 2018, Governor-elect Kelly asked me to be on her cabinet, so I did that. For 3 years, I was a secretary of KDHE, and among other things, was state health officer. So I ran the COVID response for the state of Kansas for the 3 years until I stepped down just a little over a year ago, and then retired from the Army at the end of just a year ago. And the reason I bring that up is I decided I wasn't quite ready to retire, but I didn't want to do something boring. I didn't want to do something meaningless. And these forces that we've talked about here of being a doctor in an office or in a hospital or a clinic it's hard. And especially during COVID, we saw so much attrition in terms of our healthcare manpower, whether it's doctors or nurses. And one of the things that I felt for the whole time I've been practicing medicine is nobody ever comes up to me and says, "Doctor, can I help you?" Maybe your office staff do, but "Doctor, can I help you?" And particularly, I didn't come to expect that from the payer side of the equation. The second thing we never heard Although I thought I had a glimmer of that in 1985 and 86 when we started taking care of HMO patients, but as what Jill talked about, we didn't have any data. So at 365 days into the year, then I say, well, how do we do? And that was about the first data that we got. And I remember thinking, well, that's not going to work. But now these things are coming together in, I think, a pretty good way. But nobody ever came to me and said, doctor, I'd like to compensate you through what has become known now, of course, of value-based care for spending more time with your patients. And one of the things that with incentives that are now built into many of these plans, and Jill talked about some of them, is I call it passive sources of income. It's really nothing passive about quality, but it's meaning it isn't driven purely by volume. And I like that. I don't need to talk with you guys about this. Value-based care on one side, and I use Medicare Advantage as an example of that, and fee-for-service on the other side. And I've been on both of those purely in a fee-for-service environment. And as I mentioned, my time in the military or perhaps Permanente, entirely on a value-based care side, but we're not there now, and certainly not in this geographic area. And I'll tell you in a minute what Optum is, because it's not obvious to everybody. So I should put a teeter-totter under there and saying, where are we teetering and tottering? And right now it's very heavily on the fee-for-service side of the equation, and certainly in these 39 counties where we currently are, although we're expanding through both Missouri and Kansas, it's still very much fee-for-service. But in this 39 counties, the medical groups are highly owned by the large health systems, the KUs and the Advents, the HCAs. And it'll be a tougher nut to crack when it comes to moving off of the crack because of the health systems that own these medical groups are very much wanting to leverage that control to make that, call it what it is, inertia to remain the same. Let me say just a comment about Optum. Optum is owned by United Health Group. Optum is the primary driver for United Health Group's success, Fortune 5 company. And it's interesting because we are not a health insurance company. United Health Group owns United Healthcare. That's the health benefits side of the equation, otherwise known as health insurance. Optum is a care delivery organization. So what you can think of Optum is an IPA. We're a large, many medical groups. Jill from Centris talked about that, and we have many of those same groups that are in our contracted network. We will eventually, like other parts of the country, with Optum have been in business for 20, 25 years, particularly on both coasts and the southern United States. We are different here, though, in the sense that in all these other areas, they started as a large owned and operated medical group. And we came in here in a white space on a map. The Optum has not had any presence in the Midwest. So it's been an interesting year. We just went live 1/1 of this year, and we will be expanding from really all the way up through the Dakotas. I didn't mention, I said I had 5 careers. The one I forgot, you're counting, I could see. But Lee, what about that other one? 26 years health system chief medical officer. So for half of that, I was Swedish Health System in Seattle, where I practiced for 20 years and was the CMO there for about 13 years. And then, but I'm a Midwesterner. I grew up in Iowa, College Medical School in Minnesota, low draft number. It's the only lottery I've come close to winning, unfortunately. Number 7 on the draft. So I went ahead and enlisted in the military at that time so I could maintain some semblance of control. But I moved back. I want to get to the Midwest, love Kansas City. And that's the home base of my specialty organization is here. And so I've been coming here since really about 1981 on at least every year, 1 or 2 times. So I went to a party, and then the next thing I knew, I was the chief medical officer at the University of Kansas Hospital, which then became, and I helped to merge the CUPE medical group with the hospital to form the health system. And I've enjoyed all those engagements. I won't say that I enjoyed state government, and I won't say that I enjoyed, after having been in the Middle East with a security detail because of the work I did there, coming back and having a security detail here because of the work I was doing on the COVID response. Some people didn't appreciate everything we did, but I was glad to finally peel those guys off. one of the things, and I'm really focusing on the bottom part of this slide, is that, and this is not new to you guys, you're a very sophisticated audience, about the quadruple aim. And we've talked about, and I don't think I really need to say much more about affordability, quality, but we spend so much time on the right-hand side as well of provider satisfaction. Before I took this job, I was skeptical. And so I flew out to Las Vegas and interviewed with some folks there, but I spent time in some doctors' clinics because they've been doing this for 20 plus years. And I said, I have to be proven that this actually can work. And when I talked about the teeter-totter, there are medical groups and physicians that have gone almost entirely building their practice on a value-based care model. And what they're finding, and I'm sold on it, is through the other incentives and the way they build a team, the way they share the workload, and especially the administrative workload, which is one of the Achilles heels of value-based care. And we must do better on electronic medical records and merging it with the attestations and those kind of things that annoy the heck out of us. I really care a lot about provider satisfaction because our medical manpower pipeline is not going to keep up. It isn't keeping up. And we have to do everything, bless you. We have to do everything we can do to keep an eye on the provider satisfaction as well. And I see that so many doctors are on the hamster wheel, and how do you slow that down? How do you eventually get off of that? And one of the ways it can happen is through higher quality care, but it can't be just one doctor saying, I'm going to, instead of seeing 44 patients every day, I'm going to see 22 patients a day. It has to be a team effort, and there has to be other income sources, and there has to be other help. And that's where we come in. And I'm going to show you some things because the topic of the meeting is about innovations. And there's a couple of things that I think that were innovative that we do. And by the way, patient experience, we have people that's their full-time job working with the medical groups on patient experience, satisfaction, et cetera. I think that's been hashed out. The one thing I will say here is technology advancement still is an Achilles heel, I think, for a lot of these, because every value-based care program has a little bit different requirements. And until we kind of get together with some kind of an aggregator in the electronic record with all these other things, it's going to be cumbersome. By the way, I didn't mention, this is really critical about Optum. We are payer agnostic and we are plan agnostic. So yes, we take care of United Healthcare patients, and we will, but like in other parts of the country, we will take care of Humana patients. We will take care of Blue Cross patients or Aetna or Cigna. And so when they come into Optum then with an incentive program, we'll say we administer one incentive program, regardless of the payer. So that, back to this provider satisfaction, you can imagine what that does when it comes to simplifying. Instead of having 5 portals, let's see now, and to the earlier discussion, what patient are you again? I have 5 of you a day. Oh, but from 5 different payers, and the rest are fee for service. That is very complicated. And one of the things that I think is our strength is that we are payer agnostic and plan agnostic. We just went live 1/1. We are entirely Medicare Advantage right now, but we will be Medicaid, we will be commercial, and encouraging risk on all those things. I agree wholeheartedly about the necessity to assume risk. The couple of things that we do that are quite interesting, one is that we have a whole fleet that some of which you see there, what we call Wellness on Wheels, or cleverly named WOW vans. And we deploy those to areas where, particularly when we look at the social determinants of health in communities, it could be skilled nursing and other facilities that we will go to where the patients are. And we in this first year, we're now 9 months into it, we've looked at our tens of thousands of patients that we care for and that the clinicians in our network care for, and only about 15% of the patients, or let me rephrase that, members, it's taken me a while to get used to using that phrase, but only about 15% of the members have had what I would call a wellness exam, meaning looking at for suspect conditions, doing the retinopathy screening on diabetics, or even knowing if they have diabetes through hemoglobin A1C, cancer screening, and the like. Only 15%. And I've talked to a bunch of senior focus groups, for example, and I'll ask them, how many of you have had this? And it's very consistent, 15 to 18% have had it, and the rest have not. We could do those wellness visits in our Wellness on Wheels van. So And we'll send them all the way down to to our members in the Oklahoma border, even that far down. There's a lot of physicians that say, I'm on the hamster wheel. I'm trying to be a little different, but I don't have time to do the wellness evaluations, the wellness exams. So we have quite a number of, and have not had a hard time recruiting nurse practitioners into our program. We can embed nurse practitioners that has a way of spinning off what I would call passive income to that medical group for the use of their facility. And they can see the patients, and then they're just down the hall from where the patients are being seen by their, generally speaking, well, I shouldn't say generally speaking, primary care offices. And then finally, the next week we open the third one of it. That's a heat map. It's not a bacterial culture plate. That's a heat map of kind of where Medicare beneficiaries are in the metro area. And the 3 black dots you see at this point have are where you have community centers. Community centers have fitness areas, trained fitness instructors, a living room for socialization, a big training area for line dancing and yoga and a lot of things like that. And then we have a clinic in the back. The community centers are open to the community. They're not just for Optum members. So anybody 55 or older, plus anybody younger that's on Medicare, they can use those centers for free. And but we only, in terms of the clinic, what's that?
I did not know that.
Yeah, then you should go. You're too young, but but you should at least pop in. We have 3 of them, one in Shawnee, in Mill Creek, one in I think it's about 35th and Broadway in Midtown of downtown Kansas City. And next week we'll open a new one on North Oak Traffic Way, just north of Interstate 29. And these are so good. And it's getting people out that are isolated. And we're seeing this. We have some people that almost had barely left their house that come in every day. And so we've been very, very pleased with the community centers. And but we do staff up a clinic for doing wellness visits at the clinic sites as well. And people can do those on a walk-in basis. So there's been a big uptake, excuse me, of that. There's the living room of one of the ones. There's a fitness center. Jason there in the khakis is a certified fitness instructor. These are really great pneumatic exercise machines, very low stress on those older people. It's really been very well received. So finally, we talked about the payer partnerships, which is really something that has been underexploited. And I think we just need to do more and more growth with partnering with medical groups and payers towards common ends. Administrative services to help on the coding and risk adjustment. We have trainers. We want to make sure that we help them that reflect with accuracy the conditions that the patient has. Medical management, we've got a terrific complex case management and post-hospital discharge case management that we customize based on the person's individual. And then finally, risk transfer. We assume the risk. We haven't gotten into risk sharing arrangements yet, but other parts of the country have had it that way. We have not acquired any practices here. Matter of fact, we're the first market that has opened up without having an anchor medical group or groups. And there's groups coming to us. There's not many in this community because there's relatively small number of independent practices. I was talking to folks up in Lincoln, Nebraska the other day, and if we're 85% owned by hospitals and health systems, in Lincoln, it's 85% are independent and only 15%. So it's amazing. You go a couple hundred miles north and west, how dramatically different it is. And that's why I feel really great that we have such a strong local team, the work we do. We know this, matter of fact, when KU was one of the very first groups that signed on, it's not a secret, to be in a direct contract with us. And I could say I'm still in the faculty there, we typically move very slowly. And it has just been a great relationship already. Optum is all over the country. Every dot there, you have to pay attention on the right side, but the map, every one of those dots is an Optum owned and is an Optum market, if you will. And it's fascinating because a lot of these, they are not necessarily branded as Optum. You wouldn't know it from looking. If for example, if you look at Kelsey-Seybold down in the Houston area, or WellMed, those are Optum owned and operated facilities, but they have such a strong name recognition, there's no need to change it. But the Midwest, and you look up through the Dakotas, for example, relatively unrepresented, and that's part of the one of the things that we're doing from a growth perspective. On the clinical side, we talked about that already. I'm not going to repeat that. Economic outcomes, our immediately prior speaker covered that really well. And really so much about reducing the total cost of care, but doing it safely and with driven by outcomes. So I will sign off for now, but I will be here for questions if and when they come up. Thank you, guys.
Get done. Oh. Share.
She's gonna put this down.
Be share. Share. Whoops.
Yeah, I think instead of stopping share, just pull this other slides up and,
Too late.
okay.
All right.
But you can just leave it on share and then.
Is it shared now on the screen?
Not yet.
Okay.
Hopefully I have the right one. Is that you?
Yes, that's me.
Now let's get you to slideshow.
All right, great.
Thank you.
All right, thank you so much. It's a pleasure to be here, and I do think my talk will kind of nicely complement others as I kind of dive into some of the details of what levers are we specifically setting in terms of influencing and promoting value-based care. So first off, a little bit about me. So I'm a Senior Director of Operations and Population Health Management here at Children's Mercy, Kansas City. In terms of my background, I have over 15 years, actually over nearly 20 years of experience in healthcare and over 15 years of experience specifically within value-based care. I was working up in the Wisconsin market as the Director of Business Intelligence for a multi-health system accountable care organization, and then have now been here for a little over 9 years, helping to lead our operations, strategy, and analytical functions of value-based care. Well, let me see if I can get rid of this. Well, sorry, you can't really see the top there, but it just basically, all right. All right. Let me see if I can just make this, I don't know how. Okay, well, just a quick overview. So I work within an entity that's called Children's Mercy Integrated Care Solutions. This is essentially the clinically integrated network or the accountable care organization of Children's Mercy. And as you know, within this entity, we are partnering with independent community pediatric practices, as well as federal qualified health centers to do the value-based work. And you know, what does that mean? It's really already been articulated. But just like Jill had mentioned, really the backbone of our infrastructure is around supporting practices and medical home capabilities, but then now furthering that in terms of investment in population health management solutions, deploying that and enabling them, and really allowing our network to focus on high value, integrated, and whole person care. You can see some of our operating principles on the bottom, really in alignment with what we saw earlier with the triple aim or the quadruple aim. We are very much provider-led. We focus a lot on transparency and use data to drive our strategy and operations. When we partner with our practices, and there's close to 30 to 35 practices that we work with, and when we work with them, we are supporting them on all of the patients that they're serving. And I think that's a really important piece, because when you go in and you start changing the payment
down the line, will he still be?
When you change the payment model, you have to also, you know, correspondingly change the care model. And when you start making those interventions or those changes, you can't do it just for a subset of patients. We really have to support the entire practice. And so we do operate, though, two networks, and this basically allows us to facilitate the advancement of value-based agreements by payer type. And so we have the Pediatric Care Network, which helps advance our Medicaid value-based agreements. And just for context, we have value-based agreements with 2 out of the 3 managed Medicare organizations in Missouri and 2 out of the 3 in Kansas. And that's a total of 180,000 pediatric patients that we're responsible and accountable for. Then in terms of the commercial value-based work, we have close to 100,000 lives. And this is with 3 out of the 4 major pediatric commercial payers in our market. And when you kind of add that all up, we're now looking at 280,000 value-based patients, approximately 50% of all kids that are in one of these value-based arrangements. But I think, I apologize, I just want to get rid of this. Anybody else know how to?
What are you working on?
Like the toolbars.
The toolbar.
Oh, you know what? I asked about that before, and you can either drag it to the bottom, but when I asked about it before, the tech person here said it just doesn't go away. I
Okay.
think you can drag it to be on the bottom, though.
Oh, there we go. All right. I don't know if that'll help or not, because now I'll.
No.
All right, well, all right, we'll make it work. Okay, so, but that still doesn't really answer kind of where we are in the spectrum of value-based care. So again, this audience is kind of very familiar with the spectrum of fee-for-service on the left, and then fee-for-value on the right. So taking on that full risk, being capitated or being paid a risk-adjusted per member per month for the patients that we're responsible and accountable for their health outcomes. And so we have that in place for those Medicaid agreements, and a part of that has been because of our history as a managed care organization. But we sold that health plan, and since 2011, we've continued to remain fully capitated. In terms of our commercial agreements, they're in what I would say is kind of these intermediary or transitionary models that are helping to support that advancement to take on further risk. And this is pay for performance, and then shared savings models that both have upside as well as downside risk. But I think it's important to kind of see this, because this is the sandbox. And when we think about innovation, and I talk about innovation in some of the next few slides, as you move further to the right, that's what allows you to innovate. It's going from plastic shovels to actual like gardening tools as you're moving to the right. So just being able to have those things at your disposal to kind of truly drive some change. This is just a map to kind of show where our geographic presence is. Again, close to over 30 practices in the federal qualified health centers that we work with here in the KC market. Okay, so a lot of when you kind of step back and look at how you drive behavior, a lot comes down to incentives. And we have 2 different incentive model approaches that I want to outline here. And so within our Medicaid agreements, we're in a unique position because we actually design and administer the value-based program for primary care practices, but then we also partner with them and help them to be as successful as possible in that program. So we're kind of functioning like a payer because we're funding the PCP incentive through our capitation, but then working with them and doing so by working with them in regular clinical quality meetings, both as a network overall, as well as specifically with those practices to evaluate like where is their performance, where's their opportunity, how can we help tailor their actions. And it's not just about data. I mean, we talk about data. Data is a challenge for us, but now you have a lot of data, and what do you actually do with it? How do we drive insights? How do we drive action? How do we influence the behavior that actually occurs within the clinical workflow? Within this model, we do fund 2 incentive pools. One, a pay for performance that's based on engagement, quality, and cost and utilization. And I'll talk a little bit more about that here. And then we also have shared savings. This is very similar to other payer programs, but if we can bend that cost curve, or if we can be lower than that total cost target we'll be sharing in those savings with our primary care partners. And then on the commercial side, it's similar, but obviously we're not designing the value-based agreements. We're working and we're trying to align them as much as possible. But then importantly, we have the funds flow through a common model. And it's really important to us is that much of these funds, we try to flow to the physicians as much as possible. We need the money there to promote the and influence the behavior and the investments and the changes to the care model. You can't succeed within value-based care unless you're changing both the payment model as well as the care model. And then I'll talk about some of the other buckets here as part of some of the innovations that we've had over the last few years. So we heard this earlier, but you have to simplify like how providers interact and work with payers. So one part of the value proposition of how we work as a network is they're not being evaluated on their performance with Blue KC or their performance with Cigna, their performance with Aetna. We're looking across all of our payer agreements and setting one target, and that they're focusing on transformation of the care within their practice. The next piece here is just having a balanced scorecard, and we use this, and this is updated on an annual basis. It's built into the incentive model, like I mentioned before. Our weighting of points is as shown here. So we have 10% for engagement, 60% for quality, and cost utilization is 30%. You may think, oh, maybe cost utilization isn't high enough. We really emphasize that in order for us to earn incentives and do well within these programs, you have to also be able to address the total cost of care. So it's really even higher priority in terms of being able to be successful in these agreements. On the engagement side, I mean, it's things that you expect, but this is how we get them to participate, a lot on maintaining and sustaining the data feeds. And we also we have key topics that we push out and have requirements that everyone is completing certain education of year, whether that's on how we use our population health solutions, how do we promote health equity or address better connections to address social needs. On the quality side, again, we set the one target. I've already mentioned that. One thing that's important is by having this additional model, we flex the model to benefit the practices. So in the payer model, they may not have an improvement opportunity, but then we add that so that the lower performing practices still have an opportunity to earn a high degree of the incentives. And then same thing, we noticed that a lot of our practices, or some of our practices, were performing above the 75th percentile very consistently. We iterated on that, and now there's a component that they can earn more by pushing their quality performance even higher. On cost and utilization, we have what we call both network-wide measures as well as practice-level measures. I've already talked a little bit about the network-wide. The thing I'd mention about the practice-level measures, it's really important for us that they have to be impactable by the primary care practice. So like, what can they influence and control? And, thus far, we've really focused on avoidable ED visits. What can they do to extend the access of their clinic? What can they do in terms of educating patients and families? How do they navigate to their, some have put tools on their websites so that they help to triage or know where to go when to seek the right care at the right location. So just to highlight, some other things too, we really focused on simplicity and transparency, understanding what the measure definitions are and how they can perform. One thing that we've also recognized is that practices and providers are often at different stages of where they want to drive their improvement. So we create infrastructure that allows them to access those tools, those resources, or those tactics when they're ready to focus in that area. And then we also are very transparent of, okay, if they take these actions, what's the result going to be? And what does that mean, or what's the estimated result in terms of the financials at stake for them and for their practice? We talked about this, or it's mentioned earlier, just the importance of data. But again, I kind of want to emphasize now we have all of this data, we have all this payer data, we have clinical EMR data, we have data from labs that we've partnered with. But now how do we actually take this and make it meaningful and integrate it within the clinical workflow? We like to think that if you're not bringing that information to the clinical workflow, you're really not going to have an impact on the care as you would intend, right? So how are we influencing both quality and cost of care? And we're doing that through a solution that we've invested in that functions agnostic of EMR. So as patients are as care teams navigate in their native EMR system, this solution functions in the background and it brings the information to the forefront to them that's relevant to their patient across all of these 30 practices that we work with in the community. And what does that include? Identification of care gaps, looking at what their acute visit history over the last 12 months and being able to see and drill into that as to what's happening with them. We also integrate our specialty visits, including the notes associated with those specialty visits when they're at Children's Mercy. Again, how do we make the care that they're providing as efficient as possible? And we're also supporting the referral process. So you think about care management, care navigation, how do we connect patients that are in need of those services seamlessly and effectively? And we've also integrated our social determinants of health screening referral capabilities. So screenings are done within our practices, but we've partnered with Find Help and it's been branded as Lift Up KC, but that workflow is integrated within this interface to facilitate closed loop social need referrals. I think I have to hurry up a little bit. So just a few other things on just kind of the overall network innovations. We're trying to, I like to say, crossing the value-based care chasm, right? So we need to kind of continue to take this time to invest in those capabilities for the future. And how are we doing that? We created a reinvestment account. So we're allocating funds at the network level that really the investment or use of those funds wouldn't be practical or beneficial for any single practice to do on their own. And so now we've allocated those funds, and things that we're looking to invest in is either centralized behavioral health services, asynchronous e-consultation. So how do we raise the acuity that can be managed within a primary care setting, as well as we're launching a new value-based program to extend our network to include behavioral health entities. We've also created a lost reserves account, and that's really to just help us prepare and give confidence to our providers in the community that we can increasingly move towards taking downside risk, because we agree, as others had said, we're moving in that direction. And then nationally, we know the importance of health disparities, health equity. This is where we identified that that's coming. And so how do we proactively do that? And we included engagement requirements of our practices that they had to improve how they are collecting race, ethnicity, and language data. And that was embedded into our incentive model. This is just a quick overview. I'm not going to go into it in detail, but I want to call out that innovation isn't just happening from a provider standpoint, but it's happening from payers. So I want to commend Blue KC, because a few years ago, they were really innovative in pushing and advancing social determinants of health requirements within their value-based agreements. And it's evolved from screening to then requiring the actual interventions and documentation of those interventions. And it really prompted us to update our incentive model, but also a significant operational investment in doing this work, supporting our practices on the screening processes, investing in the technology to make this closed loop referral possible, investing in the training and education. And now we're even funding community-based partnerships with community-based organizations. We have 5 across the Kansas City region that we have funded partnerships with them on closing these closed loop referrals for social needs. And then I mentioned this earlier, but a new area that we're innovating in is that we have kind of addressed 2 legs of this stool in physical health and social health. But now how do we address behavioral health? And so that we're just launching or setting up a program right now to extend our networks to include behavioral health entities. And then I'm going to well, I guess I'll make a couple of comments and then close, just because I know we only have 5 minutes. we still have a lot of work to do, especially. So John, I really appreciate your comments because we have lots to learn. It's really tough. It's at the micro level, and the incentives are not aligned well with specialists. We've started to do some innovations here because we're taking a % of our shared savings and we're putting it into areas that matter to our specialists. And that's in guiding research specific to value-based care. We have this in our faculty practice plan, which actually has quality, safety, and value champions to help us guide and advance that work, as John had mentioned. And then we also have some funds that are dedicated to performance improvement. I'm just going to leave that, and then just the kind of key takeaways here. Transparency is being really critical to the work that we've done, aligning to payer agreements, but then flexing. Really, I think the important piece is flexing to drive that engagement in care model innovations. We look at that in terms of future trends and kind of where we're going to test future features and prepare for the future. And then on the bottom here, the partnerships across the care continuum, really looking to see how do we formalize those partnerships, both with community-based organizations and behavioral health entities. Thank you all.
Okay, wow. Thank you to all of our speakers. I mean, my mind is swimming right now, and I know we don't have a lot of time for Q&A, which really breaks my heart because I have a million things I would love to bring up as well. But I just want to say that, you know, I mean, this is obviously, as we all know, I mean, we're talking about how do we move from, you know, how we deliver healthcare fundamentally in the United States in fee-for-service medicine to value-based healthcare. And I love hearing all these wonderful innovations in this space. We've heard a lot about, you know, and especially working in like with the commercial market and some of our commercial partners, you know, present and speaking. And also, I think, you know, kind of the new trends that Medicare is moving in and kind of CMMI's new direction and their new strategic plan of a lot more, you know, alignment with primary care and specialists, and how do we change the way we pay, you know, these docs or incentivize them or disincentivize them, and where do we insert the behavioral economics, et cetera. And so, I mean, I just like, there's some things in the chat about, you know, integration. There's a lot of, but I don't want to have my questions lead. Is there anyone in the audience who would love to ask any of their burning questions to any of our panelists before we conclude?
I'd like to ask John a question. You know, one of the things I didn't mention, but I think a lot about is comp plans. Because, you know, if value-based payments are made to a medical group, but it doesn't percolate through to the physicians and the staff for that matter, then it seems to kind of go nowhere. We've been looking at groups that are quite engaged in our value-based care programs and comparing the ones that are not at all engaged in, and not surprisingly, it's rather tied to comp plans.
Right, well, that will prove itself to be a failure.
Yeah.
Anyway, because that's what the money's for, is to reward those who provide the best care. And if you stop doing that, that's care.
What do you think about it in terms of the care teams as well as the providers? That's in the specialty setting. Oh,
Yeah. I think that's an interesting question I've never heard, so I have to kind of think about it. But I think it's really the person who holds the decision rights to the patient's care is the most important person to influence. But at the same time, I could see there are others on the team who contribute to that environment that are really useful. That's something interesting to think of, and I can't really come up with a good thoughtful answer to this question.
Kind of the mix of the individual incentives to maybe to providers, a shared pool distributed amongst the care teams, other models like that. There's another hand. Was that Ron and stuff? Yeah.
Sure. Trying to formulate my question. You know, with your presentation really demonstrated, I think, what you can do when the incentives are largely driven by capitation or some form of global risk. And I think, you know, when we think about Kansas City, and it would be nice if we had a sort of the whole land, you know, categories 1 through 4 continuum to sort of And if you're not familiar with it, you should, because it's a nice way to talk about what we really mean by risk. And because so much of these models are based on really fee for service. But look, you guys have really, I think, demonstrated in Kansas City a tremendous amount of movement to the real sharing of risk, which has the benefits that you described. My question, I guess, for everybody on the speakers is that works for pediatric primary care in Kansas City. What's it going to take to do that for adults in Kansas City to make that kind of a movement? Because we're always sort of trying this chicken and egg where nobody wants to do value-based care because there's no value-based care, and there's no value-based care because nobody wants to do it. So what's going to make the difference the same way it's made a difference in pediatrics in Kansas?
The way I think about it is that at some point you have to share risks and not just have it be a one-sided risk model. But that's also sharing opportunity. And I think until you have those arrangements with specialty care physicians and, hospitals, health systems, I just don't think it's going to be the high ground that we seek.
But who has to take the first step?
Well, I think those first steps have been taken, but it has to be a group that has an appetite for that.
One thing I've seen is that there are some payers who are, if they have a big commercial contract with a provider group, they will force them to take risk on some segment of the population. I'm not sure that's the right way to do it, because if it's not a meaningful size, they'll just continue to fail and just consider it a cost of doing business. But that's just one tactic we've seen from payers.
I think it'll be really interesting as CMS evolves too. I mean, think about the whole landscape of the payers and where the innovation usually happens more rapidly in the commercial market for sure because of the ability to be more nimble. But I think that, as CMS evolves and has learned so much from their prior demonstrations on benchmarking or risk adjustment or like all these things that have been extraordinarily complicated and difficult to overcome, I think the further we get along, the closer we'll get. Like, I think too, what I don't know why I was so struck with in leaving this conversation today, and I know we're really at time, but was kind of like also the piece about, which I thought was so interesting that John brought up about salary and compensation and, fully moving salary, to specialists in particular to salaries, because like, I think that's one of CMMI's biggest findings as of late. And there's this really great article I dropped in the chat in Health Affairs by Whaley et al., but it was really talking about like physician-owned versus, hospital-owned practices, and with this rapid rise in vertical integration and how we're moving to, especially in oncology and cardiology, how we're moving to more, vertical integration, like how that actually has been being shown to increase our costs of care and not really improve quality. So then what if we change payment models by which we're paying those specialists? How will that change that story? And so I think there's just so many factors at play that we keep, incrementally chipping away at it, and we're getting to better answers. But this is, how do you change United States of America? It's definitely hard. But I love hearing all the innovations we've had today. We've got time and cookies and water for networking for those of you in the room. For those of you online, you can chat if you want. We can hear you. But I do want to thank everyone and be respectful of everyone's time as well. So I want to close. Thank everyone, all of our amazing speakers, and join us in. That's gone. So I'm looking to her 2 months for our next one. And I think it is on updates on our regional quality improvement projects, both our transitions of care and opioid management. So you'll hear about how we've been implementing evidence into care and outcomes in Kansas City. But thank you all. Man, so much great work happening. Let's see.
I was wondering, like when you talked about the framework model, can they set up site in medical?
Thanks for coming.
Okay, how about?
Yes, I was supposed to.
Right, yeah.
So I turned it on.
Okay.
We're just talking about
Okay.
I think there's gonna be.
I know, and John did the beginning, and then
I think there was a track to the interview on the well, the
Oh, okay, yeah. I'm interested. They are. Cancer 2005. And she has a lot of experience at the and so, and also I recently graduated from management.
Although it's a hair.
State primary care, 40 American.
We were getting capitation.
At the time, 65. And the. So I was just wondering.
I know, it's just.
Have here, and all the stuff.